Today we're going to be performing a live spine surgery as we do every week. It's being broadcast over the internet live today on the 13th of May 2021. We broadcast live so that the audience can participate by asking questions during the surgery, and the audience can have a front row seat, so to speak, for the surgery. We broadcast with different visual modalities, and for those gamers out there, you all know what first person is and third person. This surgery will be broadcast in third person over the shoulder of the player being the surgeon, me. So you're looking over my shoulder, but then we're also going to give you a view in the endoscope, which is the tool that we use to see inside the disc. The name of this surgery is the Deuk Laser Disc Repair. It was pioneered and created here at Duke Spine Institute. The surgery is completely FDA approved with all the instruments, and we have peer-reviewed and published the results of the surgery as safe and effective for treatment of bulging or herniated discs. How's our blood pressure? Good, perfect. Our anesthesiologist has returned from her hiatus, and she's laughing and giggling over there, which is a good sign. Either that or she's been self-anesthetizing. But we don't have any laughing gas here. Maybe we do. I don't know. Do we have laughing gas? No? All right. So she's got the patient's blood pressure around 100, 110 systolic, which is where I like it. That reduces the risk of getting what's called a hematoma. And our patient is asleep. We're going to wake him up in a moment so that he can be involved in the beginning of the surgery. This is a lumbar Deuk Laser Disc Repair. Patients are awake in the beginning for thoracic and lumbar Deuk Laser Disc Repair, but not cervical. Cervical is the neck. When we do herniated discs in the neck with laser surgery, we don't have the patient awake at all. They're intubated, completely relaxed, asleep. But for the lumbar and the thoracic, we go through the back transforaminal, and we have our patients awake in the beginning, so that helps me guide the needle into the right place. Sean, did you show the audience this patient's MRI?
We have it up on the screen now.
All right, very good. So the blood pressure is still looking good. It's climbing a little bit. He's probably waking up a little bit. We do want him awake for this part shot. Now, let's see, the monitor. I think it's fine where it is. Shot, I'm right about the facet joint, a little bit inferior. Shot. So when I stand on the patient's right side, I always have a different x-ray view. By the way, Jordan, phenomenal job on the x-ray localization. Oh, thank you. Shot. How's he doing? Good. Well, that's fine. I need him awake in about a minute. Shot. Shot. All right, very good. I like. Who says that? Anybody know? I like. Sean, any idea?
About what?
I like. I don't have the right accent.
Borat?
Borat! Oh, you got it. That was a tough one. I'm impressed. Borat, that's right. Did you know that, Sean?
Yes, very nice.
Oh my gosh, yeah, very nice. You say it good. My son imitates it perfectly. He cracks me up. That's so funny. Okay, Borat, a little bit inappropriate adult humor, but he is very funny. He is very, very smart and very funny. So we are getting ready to enter the foramen. The foramen is a naturally occurring hole where nerves come out of the spine, and it's that hole that we're going to pass through. So this surgery is called transforaminal. And trans means to go across in Latin. It's a very common medical term, trans. You've probably heard of like Trans-Siberian, meaning you cross the Siberian continent or across Siberia. But trans means to pass, like to move through something or across something. So we're doing a transforaminal. Foramen means the hole where the nerve comes out. And if you look at the x-ray, which may or may not still be up, but you can actually see at the tip of the needle, which is right up against the spine, that we're about to go into a white area. That is the foramen, all right? So we want to go in there, and we want to be underneath the nerve root. How is our patient? Is he awake yet? Not awake yet. All right. So we'll just wait another minute and give him some more time. This patient had a request for me, which I don't normally do, but he wants to be asleep for the discogram. And so he has watched this surgery on the internet, and that's how he found us. And he noted that during the surgery, kind of in the beginning, once I get the needles into the proper position, that I actually do what's called an evocative or provocative discogram. Now, it's not, you know, evocative and provocative are essentially the same thing. Why are you sweating? No, I'm not sweating. I'm crying. You're crying. Oh my gosh, Luis is crying. It's okay, Luis. It's okay. I'm not going anywhere. I'm not going anywhere. I'll be here for a long time, okay? But so the evocative or provocative discogram is a test, a confirmatory test to confirm that the discs that we are actually fixing, the bulging or herniated discs that we're fixing, are actually the source of the pain for the patient. And so it's a very reliable test. A lot of patients come to me with MRIs and they think that the MRI tells us where their pain comes from, but it doesn't. MRIs never show you where pain comes from unless the patient has a tumor that's causing their pain, or a fracture that's obvious, or an infection, or discitis, okay, which is inflammation of a disc, the entire disc. The point I'm trying to make is there is no test in the world except for a discogram that will confirm and tell you for sure that that particular disc is a painful disc. So there are three possible outcomes for a discogram. And you never want to start with a discogram as a diagnostic tool. You could if you didn't have an MRI or CAT scanner, but generally you start with a non-invasive imaging, such as an MRI. And in my opinion, CAT scans are semi-non-invasive because they do send radiation through your body. So we use radiation in medicine to treat tumors and other things. So it's not really benign and it's not really non-invasive in a way. CAT scans really do send x-rays through your body, which can be harmful. An MRI is completely non-harmful, unless of course you have a medical device like a pacemaker, defibrillator, spinal cord stimulator, in which case the MRI could be harmful to you indirectly by acting upon your medical device generator computer and resetting it. So there is very few tests that we actually do in medicine that don't create any risk for a patient. One of them would be like ultrasound, for example. Ultrasound is probably the most benign test available because you're just using sound waves transmitted from the is that Sean? Is there a sound loss or something? What's going on? Is that Karen? Is Karen there? Yeah, have him bring Karen over to the phone and call back, all right? And then I'll give her instructions. Thank you. So ultrasound is probably, are we close? You really snowed them. That's all right. Ultrasound is probably, let's get an AP. Ultrasound is probably the most benign medical test we do for spine issues. And we use ultrasound primarily for muscular problems. Like if somebody has a torn muscle, like a piriformis muscle tear, we would use the ultrasound to diagnose and treat it. All right, very good. That looks perfect. So you can see that a needle tip is just lateral to the foramen, just kind of back behind the facet joint at L5-S1. All right, go ahead and go back to a lateral, please. So after ultrasound, you probably have things like an EMG, nerve conduction study, then X-rays, then of course an MRI scan, and then a CAT scan, and then you have invasive tests like the one you're watching, where we do a discogram. Is that Karen? All right.
You're unmuted.
So we've been talking a little bit about tests that are done to evaluate patients who have back or neck pain, and the least dangerous of all is an ultrasound, but an ultrasound is also the least informative unless you're looking at muscles. So it doesn't really diagnose back pain. MRIs don't diagnose the cause of back pain, okay? And that's really one of the most important messages, is that MRIs do not diagnose the cause of back pain. The surgeon or doctor has to diagnose the cause of back pain. And we use the MRI to do that, okay? We use the MRI to do that. But an MRI itself will never tell you where the back pain comes from. I guarantee you that. And as a doctor treating back pain, if you rely just on the MRI to figure out where the back pain's coming from, you will be wrong probably 90% of the time. Now, the MRI can help you figure out where back pain is coming from. However, it will not tell you definitively where back pain is coming from. I'm on the herniation right there. I can feel it with the tip of the needle, okay? So for those of you who've been paying attention, we're on the right side of the patient, on the flank. Now, we're treating a painful herniated disc. That's what this surgery does. So when you have a diagnosis of a herniated disc that's causing back pain or leg pain, that's what this surgery, the Deuk Laser Disc Repair, is for. Unfortunately, 99% of spine surgeons out there don't know how to do this surgery. So if they don't know how to do the surgery and they don't even know it exists, how could they possibly recommend it for you? They won't. They're not going to recommend it for you. If they don't have the knowledge of the procedure, if they don't have the training of the procedure, and they don't have the equipment or facility to do this procedure. You're watching the most advanced spine surgery in the world for disc herniations that are symptomatic. This is what you want to have done. You don't want what the other surgeons do. They're going to make an incision in the back, and they're going to do what's called a laminectomy. They're going to cut the back from here to here, okay? Now notice the difference. We're actually coming from the side. All the other surgeons come from the middle. I was trained to do this surgery first from the middle. So I learned how to do the microdiscectomy. And in the middle you have a spinous process that's connected to what's called a lamina, and then a facet joint, okay, above and below. There's a facet joint above and there's a facet joint below. And then there's a pars, and all of this is bone, okay? And then there's a herniated disc right here. So to get to the herniated disc, you actually have to remove part of the lamina and part of the facet joint. The facet joint is a joint that stabilizes one lamina to the next. It keeps your spine together. So once you start removing the facet joint, you're going to weaken the spine. And that's what microdiscectomy is. That's what laminectomy is. All those surgeons are going in the middle of the back, going down to the spine, peeling the muscles off the spine, and then they're seeing the bone and they're removing the bone of your spine to get to the herniation, which is in front of the bone. We're actually going around from the side. So we're not taking any bone or joints or ligaments out of your spine. And that's one of the biggest differences with this technology, is it's a lot safer and better for the patient because we're not removing normal parts of the spine to get to the abnormal part. All right, we're ready to pass into the disc. Is he awake? Now I can feel the herniation. All right, let's see where we are. Shot? So we're bumping up against the bottom of L5. I'll redirect, and that should take us right into the disc. Wait. Is that where we are right there? All right. So for those of you looking at the X-ray side view, it's a lateral view, you can see that I've accessed the bottom disc, L5-S1. That's his worst disc, herniation. The one above is smaller, but still significant. The one above I don't believe is causing any of his leg symptoms, but it is causing back pain, so it needs to be fixed. He doesn't want to, he's traveling from out of town like a lot of our patients, and he's doing what's called medical tourism, where basically you leave your area where you live to find the best medical care. There's nobody where he lives that does endoscopic surgery like this. As a matter of fact, there's nobody where you live unless you live in Brevard County that does it, because I'm the only one that does it. Hey, what's going on here? What's this blue thing here? You're supposed to take that off?
No. Let me see.
Did you buy a...
That's probably with the other case, this cover that comes.
All right, but yeah, the needle looks fine. It's the same type of needle, right? So we're good. All right. So basically, if you want the most advanced surgery in the world for a herniated disc that's causing neck pain or back pain or even thoracic pain, you need to come to Deuk Spine Institute. It's pure and simple. There's nobody else that does this surgery, and there's no one else that has the safety and the effective results that we do. All right, we're going for the L4-5 disc next. So we're going to do 2 discs with 1 incision. Shot? So what am I passing through right now? What am I going through to get to the spine? Is this dangerous? Of course, any surgery is dangerous, but I've gone through the skin, which is not dangerous, and now underneath the skin is some fat. I've gone through that with the needle, and then I hit the fascia, the covering over the muscles, and I went through that. Then I'm going through the muscle. And basically, the reason the surgery is so safe is because it's A, minimally invasive, but B, we're not removing anything that's significant. We're not going near any major blood vessels. We're not going near the heart, the lungs, anything like that. We're literally passing through the muscles of the back. And the muscles are important structures, but it's honestly really hard to damage a muscle with a needle. You can't. It's virtually impossible. So it's an extremely safe procedure. Now I feel like I'm in the foramen, and I'm heading for that L4-5 disc. You got to make sure your first needle doesn't deflect your second needle. Otherwise, it could push the needle to go somewhere you don't want it to go. You can actually see the shadow of the herniated disc at L4-5 right in front of the needle. It's a bulging out. So this is an L4-5 is a disc bulge, which is a small herniation, but still a herniation. Disc bulges, a lot of people misunderstand. They think that they're not important or significant, but they actually are. Disc bulges are probably the most common thing we operate on with the Deuk Laser Disc Repair. And the Deuk Laser Disc Repair is the only surgery in the world that has been published to proven to fix disc bulges. All right, we've got both of our needles in place, and we're ready to get started. Are you awake? Everything's going very well. We're going to put you to sleep now. Anyway, I guess his blood pressure was low because he was on propofol, but maybe we can get that down. If you want to put him to sleep, that's fine. We're going to put you to sleep now. You know, I know you didn't want to be awake for the discogram. So when you wake up, we'll be done. Nighty-night. So you know, I don't make it a point to keep the patients asleep for the discogram because I want to confirm that these two discs are the source of the pain. But based on his physical exam that I already did, the localization of his pain on physical exam, the quality and characteristic of his back pain, I'm certain that it's due to the herniated disc at L5-S1 and L4-5. And the MRI shows structural abnormalities at 4-5-5-1 that are consistent with discs that cause back pain and leg pain. Let me know when he's asleep. Can you count? I like when they count from 1 to 100 out loud so I can hear when they're basically stop counting, they're asleep. Can you have them do that, please?
Can you count from 1 to 100, please? Count out loud.
Count out loud from 1 to 100. Keep going. If you get to 100, we don't pay the anesthesiologist. Let me know when he's asleep. So at this point, what we're doing is deep inside his back, he's got these two discs, L4-5 and the L5-S1. And there's tear in the back of each disc called an annular tear, and then there's herniations associated from those annular tear, where the jelly is squeezed out. Thank you. Normally we would do a discogram and find out how much pain each disc causes, but he didn't want to be awake for that, so he's going to be asleep. Now take a look at the incision. The incision is 7 millimeters. You see this, Sean? 7 millimeters, folks. If this patient had back surgery with another doctor and they did open surgery, they'd be looking at an incision that's at least this long. Bigger incision means more pain, more scar tissue. And patients who have this surgery, the Deuk Laser Disc Repair that we're doing now, they don't take narcotics after surgery. They don't need opioids for pain. See, when you do an open surgery and you got to move the muscle off the spine, you got to give the patient post-operative muscle relaxers and narcotics. So this is a much safer surgery from the standpoint of patients after the surgery don't take narcotics. Okay? Whereas patients with hospital surgery or any other surgery that other surgeons do, like a microdiscectomy or laminectomy, they're going to need to take narcotics. So this is a non-addicting type surgery. There's our discogram. Go ahead and zoom in on that. So pull your fluoro to the patient. I want to give you a good view of that discogram because you can see the tear in the back of the disc is huge, where the black dye is leaking out in the back and then running around the nerve root. So that tear is where the back pain comes from, the posterior tear. And I was the one to discover that, and I'm the first surgeon in the world to treat it. So that's why this surgery can only be done here, because nobody else knows about it or treats it. Shot? All right, so this one, the dye is not really leaking out very much, so this will be a quick one. And that's the L4-5. So the really bad one is 5-1, L4-5 is not so bad. But there's definitely an abnormality. And, huh? Let's start with 5-1.
Okay.
Yeah.
Do you want to put the other one?
No, it's all right. At this point, I'm placing what's called the guide wire shot. And once the guide wire goes in, I can take this needle out that we started with. And you got to be careful not to pull the guide wire out while you're doing that. Now, we broadcast these surgeries for educational reasons. We want to educate the public on what's available in spine. Here's the problem, folks, okay? To fix this man's back and get rid of the leg pain, he needs a microdiscectomy or a laminectomy traditional surgery, if you go the route of traditional surgery. Both of those surgeries involve huge incisions, damage to the muscle, tremendous amount of scar tissue, and the bone has to be removed out of the spine, thus weakening the spine. Listen, your spine is called the spinal column. There's a reason it's called the spinal column. It is the only hard thing in your body. And the moment you start drilling away and removing bone from the spinal column, you're weakening that column. And so you got to ask yourself, if you weaken the column enough, what happens? What happens is the spine starts to collapse and twist. You get scoliosis, you get kyphosis, you get restenosis, and you get ligamentous thickening, you get reherniation of the disc. You get all these bad things happening that occur 6 months, a year later after your surgery, and you have to come back and have another surgery. So if you look around the United States and the world and you say, what's going on with back surgery? You hear stories all the time of I had 2, 3, 4, 5 back surgeries, 6 back surgeries, 7 back surgeries. Those are true stories. They're true stories because the surgeons are using old techniques and old technology, removing bone and ligament from the spine to fix the source of the pain. That's why this technology is the most advanced and best, because we're not damaging the spine at all. We're going through the muscles on the side of the spine. We're not even damaging them to get into the herniation to fix it. Now, if you do a microdiscectomy, laminectomy, and you do it properly, you can actually help this patient's leg pain. It'll go away. However, you won't fix the back pain. The only surgery that actually fixes back and leg pain is a type of spinal fusion we do here at Deuk Spine, where we actually unpinch the nerves by opening the foramen up, and then we do an interbody fusion and a posterior fusion and screws and rods. So really the alternative for this surgery for this patient to fix back and leg pain is a decompression, reconstruction, and instrumented fusion. You're talking about a huge incision, a long recovery of probably 3 to 6 months, and the patient's going to be on narcotics, and they're going to have a tremendous amount of scar tissue, and you have all the complications that can happen with big complex spine surgery. So he's avoiding all of that by doing the Deuk Laser Disc Repair. All right, why do you have that? Yeah, very good. All right, so we're going to advance the dilator next over the guide wire. So again, the dilator is not damaging anything. It's literally spreading the muscles, like pushing them apart. I can feel the herniation. Shot. All right. So at this point, I can't push the dilator in any further. I have to. Shot. That's better. I have to. Shot. I feel it going. I have to use the mallet, the hammer, which freaks a lot of people out. But, you know, if you saw what we do for open back surgery, you better get a Kleenex. This is a lot less invasive. So far we've had 0 blood loss, okay? Unless you consider that blue stuff blood, which it's not. Nobody has blue blood except aliens, you dummy. All right, so we got to bring the, let me just show you what we're doing. Maybe he is an alien. Did anyone know surgeons have a sense of humor? They do. Some of them do. All right, this is the whole surgery, folks, will be done through this tube. Can you see that, Sean?
Yes, we can.
And people ask me sometimes, is this FDA approved? 100%. It's illegal to do any surgery or any treatment in the United States unless it's FDA approved. So we do only legal surgeries here. All right, this is the tubular retractor. And basically you can see what it does is it holds the tissues so you have a path. It holds all the muscles and tissues open. But look how skinny it is. It doesn't do any damage to the skin or soft tissues or muscle or fascia. And basically it's just a conduit so I can bring the scope down and the laser and get inside the disc to fix it. So I'm going to put this over the dilator and I'm going to advance it, and I usually twist it just so it doesn't get caught on anything. The twisting helps with that. And now I can feel I'm up against the facet. And of course I'm just not going through the facet, I'm going around it. Shot. 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 All right. Yeah, his nerve is extremely irritated. I need the device. So I'm going to take this dilator, the dilator out. It's taking the tube with it, shot. So I've got to separate the two so I don't take the tube out. You have something I can grab this with? Coker? Let's try a coker. Yeah. Let me have it. I don't think it's going to work, but we'll try it. Oh, it worked. Good. So now we're taking the shot. Let's see where the tube is. Perfect. It's inside the disc. And one of the advantages of this technique is we get to push the herniation from in the foramen back into the disc. And then I'm going to remove it. I'm going to remove the herniation from the disc itself, from inside the inner body space. Now I can feel his nerve. His nerve is very irritated. So it's probably very tight in there. So now we have a conduit. I'm going to bring the scope in. You all see the scope here, Sean?
Yes, we do.
All right, we're going to bring the scope down, and we will be inside the disc when we get in there. I'm going to bring some irrigation in so I can wash away all the material. All right. So there we're inside the disc right there. There's the tear. And I need a grabber. Now we're going to start fishing out some herniation pieces from the L5-S1 herniation. See what's available, what's loose and free. Sometimes we get lucky, we get some big pieces. But the herniated fragments are frequently scarred to the annular tear. So that's why it's really an annular debridement. A lot of people don't understand that. We're the first to do the annular debridement in the world. The first to do it. And it's the annular debridement that's the key to the success of the surgery. That's really what sets the Deuk Laser Disc Repair that we're doing right now apart from every other spine surgery that operates on the disc. We're not the first to operate on a disc, but we're the first to do what's called an annular debridement. And the annular debridement is essential to curing the back pain and the neck pain or thoracic pain. These are all pieces of herniation. We're going to get our laser in just a moment, but I'm using a tool called the pituitary rongeur to fish out pieces of herniated disc. Remember, many of these pieces were sitting in the foramen up against the nerve root when we started. And by pushing the dilator, there's a nice one, by pushing the dilator over the guide wire into the herniation, we're actually reducing the herniation directly without causing any damage to the rest of the spine. That's the miracle of this surgery, is that we're not damaging the normal body except for the skin incision, which is so tiny. We're not doing any damage to any of the normal part of your body to get the herniation out, whereas every other spine surgeon in the world is. And the reason why they do it that way is because they don't know any better. They literally don't know any better. That is the only reason. That's not what you want to hear from your spine surgeon. I'm causing permanent damage to your spine because I don't know any better how to fix your disc. But that's exactly what they're telling you if you listen carefully, because they don't know any better. And that's why we broadcast, because you should know better. It's your body. You as the patient have to live with the sequela of a surgery, whether it's intentional damage as part of the surgery, what's called the exposure, or whether it's inadvertent damage through a complication. Both inadvertent damage, complications, and intentional damage are unacceptable in my mind when you have this particular surgery available to fix your problem. There's no reason you should subject yourself as a patient to accepting damage to your body's normal structures in order to achieve a tactical solution, which is to cure the herniation and the annular tear. So many reasons to consider this type of surgery, Deuk Laser Disc Repair, for your, there's the tear, by the way, look at that thing, all scarred up. It's all white and scarred. So that's what I'll be working on, as well as removing the herniation. I have to debride this tear. All right, standby laser. So we have 2 discs to fix today. This first one is going to be the worst, and it's going to show you the most damage. You see the gold stuff down there, or at 3 o'clock? That's calcification. That comes from chronic inflammation and your body basically attacking that area, trying to fix it for years. So this patient injured this disc years ago and has had inflammation in the disc that's causing back pain and leg symptoms. And that's what we're here to fix today. And the whole source of the back pain and leg pain is right here. That's what we're working on right now with the laser. The blue thing at 12 o'clock is the laser fiber. And it's really a glass fiber. It looks like it's plastic, but it's not. And the way it works is there's a machine you can't see in the operating room right now. And Sean, you know how we're doing those highlights of some of our technology?
Yes.
We should do the laser next so people can see it and you can reference it. Okay. All right? And we should actually do a web page as well. So have Zach build a web page on it, but show the actual laser machine and have the blue cable coming off of it, and maybe have Luis show you and you can take some pictures, and then you can explain to the audience how it works. But basically this giant machine called the Power Suite delivers about 30 watts of energy through this glass fiber from 6 feet away. And it basically, the laser energy is a type of what's called electromagnetic radiation, which is the same type of energy that light is, that plants use for photosynthesis, or that the microwave uses to cook your food, or that basically there's different wavelengths and frequencies along a spectrum, and the laser energy is a very high frequency, high energy form of electromagnetic radiation. So the laser beam travels from 6 feet away, where it's generated in a machine at the patient's feet. It's the size of a giant suitcase, maybe 2 suitcases, and we have a technician operating it. And basically, it delivers that energy right to the glass electrode you're looking at. This is all scar tissue from the annular tear right here. It's amazing. It's bad. So this is the worst part of it. Got to try to get rid of some of this. And the laser energy comes out the end, the tip of the glass right there that you can see, and it literally travels about half a millimeter. Half a millimeter. You know how far a millimeter is, right? So it really only travels in a liquid media, which is what this is in. See all the things moving and shaking? That's because we're running what's called irrigation through this tube. So we use cold irrigation, usually normal saline, or it could be lactated ringers. Typical surgical irrigation. We run it through this tube, and that's what makes everything move and shake for the most part. All right, so I'm not using the laser right now. So whatever shaking and moving you're seeing, like down there, that's from the irrigation flowing through. So the irrigation is necessary in order to remove bits of herniation that I'm blasting away with the laser. But the laser only delivers energy right at the tip. Okay? So it doesn't like shoot around the room like in Star Wars. Unless I want it to. Unless somebody's misbehaving. And then we use it like a weapon. It's funny, when I say things like that, some of my staff actually believe me. Like I was upset with them a few weeks ago when I said, you guys aren't going to get any food for lunch. And I was joking, and somebody complained about me. It's pretty funny. And then they quit. So it's like, are you kidding me? If I tell you can't eat lunch today, are you going to take me serious? Right? So you've worked around doctors and surgeons enough, you know that we have a sense of humor. Right? Sometimes it's very dry and maybe even inappropriate at times, but it's still an attempt at humor. Right? Anyway, getting back to the surgery itself, you can see when the laser touches tissue, it basically breaks it up. How does it break the tissue up? Basically, there's two ways. One, it delivers energy, electromagnetic energy, to the tissue, and the tissue just like disintegrates as a result. And then it sends a shock wave, literally a pulse, like a sound wave through the liquid, okay, that's in there. So if there's no liquid in here, then you will not get the pulse wave. You'll get it in air instead of the liquid. And that pulse wave actually, by the way, that's a piece of herniation right there. That pulse wave is going to break up the tissue even more and kind of loosen it up. So the laser really works in two ways. It vaporizes the pathological tissues I want to get rid of, the herniation and the annular pieces of the annulus that are full of scar tissue and calcification and basically areas where there's inflammation, what's called a nidus of inflammation. I want to get rid of those. There's a piece of herniation that came out. And so I want to get rid of them, and the way I get rid of them is by breaking them up. You can either cut it out with a blade, or you can try to grab it out with the pituitary, which is kind of like a blade, or you can blast it out with a laser. And I'm going to tell you right now, there's no way to put a blade down there, okay? Laser off, because that's a 6.5 millimeter tube. There's no blade that goes down there safely to do the job, period. So if you look at this tool right here, this is called a pituitary, right? If you look inside carefully at the edges, you can actually see that the sides of this thing are like a blade, okay? They actually not just grab, but they cut. But that's about the only blade you can put in there. There's a herniation right there, folks. Okay? It's not, it looks big, but it's not huge because we're using microsurgery basically. We're doing microsurgery. And, you know, things look big under microsurgery when they're not that big. Right? There's another piece. So if you look down here, things look big, but if you measure from one side of the tube right there to the other side of the tube right there, that's about 6.2 millimeters. So 6.2 millimeters is pretty small. Here's another piece of herniation. Look at that. Oh yeah, I didn't really get it all, but and you know, this is surgery is just picking away at the herniation piece by piece. Rarely do you get a giant piece coming out. You know, it's kind of like when you go hunting. Oh, we got a biggie. Oh, get the light on. This is going to be a big baby. You did labor and delivery, right? Well, check this delivery out. Wow. Smack its ass, give it an APGAR score. Look at that thing. That was one of the herniations in the foramen that when we put the dilator in, I shoved it back into the disc through the annular tear. And we just took it out, we delivered it. It's a blue baby right there. All right. How does it get blue? Well, you put a blue dye in. Okay, the blue dye, here's another one. I guess we got twins. The blue dye stains what's called nucleus pulposus. The dye does not stain the annulus fibrosus. It stains nucleus pulposus. And by staining the nucleus pulposus, it stains only abnormal nucleus pulposus. Okay, this is important. So the blue dye only stains the jelly in the center when it's been degenerated from inflammation. And this is something that a lot of people don't know. Okay, they don't know it. And what I mean by a lot of people is I mean like almost every single spine surgeon in the world doesn't know this. There's another baby. We've got triplets. I'm saying this because we have a nurse here who's interviewing, and she works in labor and delivery. And so, but we do call it delivery. We are delivering, you know, just not in a typical sense. See, it's not so different from OB-GYN, you know. You fit in perfectly. All right, so I'm making my way out. Little by little, there's the tear. You see the white thing there? That's what has to be debrided with the laser. Again, for people out there that tell you lasers and spine surgery are unnecessary, they have no clue what they're talking about. That's like saying that a hole, if you know what a hole is unnecessary for a boat. You can't have a boat without a hull. I mean, you could try to stand on top of a piece of plywood, you won't have a hull, but every boat made has a hull. In other words, this surgery cannot be done without a laser. It is, I think, it cannot be done properly without a laser. Now, could you float on a flat piece of wood? Sure, but it doesn't really make a boat. So the laser improves the safety, the efficiency, the effectiveness of the surgery. So what do all those words mean? Safety, efficiency, effectiveness. I say them, but most people don't understand what they mean. Well, safety means you're not going to injure something that you shouldn't be injuring, like the nerve or tissues in the body, like the spine, the bone. You're not damaging something that shouldn't be damaged. So the laser is extremely safe because it emits a laser beam only 0.5 millimeter away from the end. In other words, it doesn't shoot around everywhere. So the laser is far safer than a scalpel, for example. You know, people can actually get hurt with scalpels. You can cut yourself, you can cut the patient, you can cut too deep. You can't actually see. With a scalpel, you can't see where the blade is. Most surgeons won't tell you that, but that's the God's honest truth. You don't see the blade cutting through the body. You stick it in and it disappears. Okay? It disappears not just from you, the observer, it disappears from the surgeon's view. The surgeon can't see it either. They're just guessing how deep it is. Okay? I mean, we get pretty good at guessing, but we're still a guess. On the other hand, a laser, you can see it. You can directly visualize the business end of the laser, every single surgery. So the laser is much safer than a scalpel from that standpoint. Next, from a safety standpoint for your staff, the chance the laser is going to hurt them when it's on inside the patient's body is 0. Whereas a scalpel, as it's being passed, you know, from the surgeon to the helpers, you know, it could hurt somebody. Or if it's sitting on the table, the Mayo stand we call it, somebody could stick their hand on it and get cut. You don't think this happens? It happens all the time. Not here at Duke Spine, because we're extremely cautious, but at most hospitals there are those types of needle sticks and scalpel sticks. They happen all the time. How often do you think they happen, Zane? Needle and scalpel sticks in the hospital. I mean, it happens, right? Every week somebody gets stuck. So the laser you can't stick yourself with. So it's much safer than a scalpel for the staff and for the patient itself. Okay? And then efficient. What does efficient mean? Efficient means work over time. That's what efficiency is. Work divided by time. How much work gets done per unit of time? Let's just call the unit of time a second. So what gets more work done, aka removing the herniation and debriding the annular tear, what gets more work done per unit of time? The laser does, far more than a scalpel. Okay? Now the pituitary you saw went in and grabbed out a massive chunk of herniation. Now if I had to sit there and zap that herniation fragment with the laser, it would take me an hour. So the pituitary is actually very efficient as well, and that's why I use the laser and the pituitary. So from an efficiency standpoint, the pituitary and laser combination is the most efficient way of fixing this. Now there is another way I could do it, but it's dangerous. I could take what's called an agar drill bit, which is a special drill bit that actually pulls tissue backwards, like most drill bits do. and I could stick it down here and turn it on and just start drilling this disc. All right? So if I didn't care about the patient very much at all and I wasn't worried about complications, that's what I could do. I'd be done in 30 seconds. And I wouldn't take all this time. But those drill bits are available. I could get one. I could be doing it today, but I don't. I choose not to. Why? Because I don't think it's safe. Now, what's the chance I would hurt a patient with a drill bit? Probably 1 in 100, but to me 1 in 100 is not acceptable. I want 0 in 100. That's acceptable. So if it means me spending more of my time and staff's time and paying more for this patient to have a safer surgery, then that's what I'm going to do. I'm going to spend the time and money as their surgeon, as their doctor. They trust me. I'm not going to let them down by going cheap. I wouldn't do that for myself. I wouldn't do it for my wife. I wouldn't do it for my kids. I wouldn't do it for anybody, probably not even my worst enemy. I wouldn't do it, okay? Because I don't believe as a doctor you should harm people. Unfortunately, a lot of doctors disagree with that statement and they don't care about the patients. They really don't. They're literally pigs. And I hate them more than I hate the insurance companies because they've dishonored the medical society and they've dishonored themselves. So, but there are a lot of doctors who just don't care, and they're perfectly happy doing treatments that are dangerous and ineffective for patients. I'm not one of them. I have a much higher standard. But that said, the drill would be the only thing that would be more efficient than a laser and a pituitary that's available, okay? But I don't do that because it's not safe. So remember the adjectives I use to describe this. The laser and the pituitary is safe, effective, and efficient. So what's the effective part mean? We've already talked about safe and efficient. The effective part means that while I'm in here, I fix what needs to be fixed so the patient gets the result they're looking for, which is elimination of back pain and elimination of leg pain, numbness, tingling, weakness. Okay? That's my goal. Now, am I going to be able to do that? Yes. Will this patient wake up and have no leg problems? Usually not. And here's why. The pain usually goes away right away. However, when people come to me and they have weakness, that's from the nerve being crushed pretty badly. And so it literally takes, 6 months to a year for the nerve to heal completely. So weakness, numbness, those are things that don't go away right away. They take time to go away, okay? They take time. And I can't speed that up. Only the body can speed it up. So basically, the patient will have to wait and be patient for, there has to be a patient. They have to be patient. They have to do physiotherapy. They have to do exercising, walking. They have to rebuild and recondition their muscles. And the nerve now that it's unpinched, is going to start sending signals now down the nerve to the muscles from the brain and the spinal cord, okay? So your brain will be able to start talking to the muscles once again. And I can't speed that up. And everybody heals at a different rate. Some people, the weakness and numbness go away immediately, and some people it takes 3 to 6 months to go away. But the pain down the leg always goes away right away. And we've had, on average, about 98% elimination of leg pain for all my patients that we've been doing. And we have about 98% on average elimination of back pain. If we do it in the neck, then same thing goes for neck pain and arm symptoms, okay? Because herniated discs in the neck cause arm symptoms. All right, we're almost done with this disc, and then we're going to do the next one.
We have a couple questions from our audience.
Yeah, sure.
One of our viewers from Facebook is wondering how much what is the temperature of the laser energy that the machine puts out?
What's the temperature of the laser energy that the machine puts out? The laser energy has very little temperature at all. It has no real temperature. In other words, if you were to look at this laser beam passing through air, it would have virtually no temperature. The only temperature it would have is the dust particles in the air that get heated up from the energy that they absorb from the beam. So the dust particles themselves would create some heat as they are interacting with the energy from the laser. But if the laser beam passes through a vacuum, okay, and there's no matter, like nothing with mass, such as dust or even air like oxygen, nitrogen, etc., that's in air. If you pass that laser beam through a vacuum with no matter, there will be no temperature. So the only way you get temperature is when the laser beam, stand by, when it actually interacts with matter, such as the disc herniation or the annular tear. Then the energy is delivered to the matter, and the matter gets hot. So the disc will get hot, the herniation will get hot. And we use cold irrigation, simply refrigerate the irrigation in a refrigerator here at the surgery center at Duke Spine Institute. We refrigerate the irrigation so that it cools the tissues, so the tissues don't burn. But if we did not use cold irrigation, then you would see a fire down there, because the amount of energy, it's just like taking sunlight and using a magnifying glass and focusing that light energy on some leaves, you know, on the ground. You'll start a fire. That energy will be absorbed by the matter, the leaves, and they will combust, because the temperature will increase to the point of combustion. So we could be having a fire right now inside this patient's back if we weren't doing things the right way. What does doing things the right way mean? Well, it's a combination of using the right amount of laser energy, the right amount of bursting, basically what's called cycling or hertz. So it's the time period of delivery. Specifically, it's the length of delivery of the energy. And so what's happening is the laser is giving energy in bursts. And those bursts are very short, on the order of milliseconds. So it releases energy for, 50 milliseconds, I'm guessing, and then stops, and then releases energy for 50 milliseconds. So you have two time periods. You have the period that is releasing the energy, and you have the period of time where it's not releasing energy. And it cycles back and forth. So to calculate, the amount of, the risk of fire, the risk of damage is proportional to the amount of energy delivered over time to the tissue. So if you deliver too much energy, you're going to get a fire. You're going to get charring and a fire, which we don't want. And then if you don't use cooling irrigation, you can get a fire as well. So we want to avoid that. This is a massively damaged disc. Yeah, no problem. Thank you. Good job. This is just, literally horribly damaged. This is all scar tissue from the annular tear. The annular tear is huge. It literally goes almost from bone to bone, from end plate to end plate. It's just all scar tissue from chronic inflammation. This patient's lived with pain for years and years and years, and it all comes from the annular tear. All right? We are just about done at L5-S1. And then we're going to do L4-5. And like I said, L4-5 is not nearly as bad as this. But, he wants to be absolutely certain we get all the pain generators in his back treated today. And that's why we're doing both discs, L4-5, L5-S1. So we're going to do that in just a minute. Great questions, by the way. Keep the questions coming. By the way, I ordered mole for everybody. Chicken mole. And I hope you like it. It's coming from Nico's. If you're interested and you're in Brevard County, Nico's Restaurant, Nikos. Don't go to Nicky's. Nicky's is terrible. Nico's is over by the Publix, and the food is amazing. The quality and taste is so good. So I ordered Nico's for everybody, and it should be here around 11ish. All right. This is pretty bad. I gotta say, this is one of the biggest, worst tears I've ever seen. It's amazing how much damage there is here. I mean, amazing. We're gonna get it. Don't worry. There's some epidural fat. But yeah, this was a big herniation. This wasn't an annular bulge. This was not a bulging disc. This was a herniated disc for sure at L5-S1. And the one at L4-5 is a bulge. It's all, look at all the scar tissue, just horrible. Right where the nerve is too. The nerve is just here on the outside. All right, what other questions do we have from the audience?
Yes, we have another question coming in from YouTube. A viewer's wondering, what is sacralized tissue?
So sacralized means usually that the L5 bone, L5 vertebral body, which is normally a normal vertebral body, is attached to the tailbone below it. So normally the L5 is just on top of the sacrum, and they're separate. They're separated by joints. In the front and middle there's a disc joint, and then in the back there's a facet joint. And sacralization means that those two bones have grown together, or you were born that way. Sorry, they didn't grow together. All right, they grew together. I'll just tell you. I don't want to confuse you, but they grew together when you were in utero, which means in your mother's uterus, or father's uterus these days, I guess. I got a good chuckle. So, sorry, I just have to be. We don't discriminate here at Deuk Spine ever, and I just want to be fair and balanced. But anyway, in utero means, you know, those first 9 months of your life when you are in the womb, and yes, I said life, that's when the bones fuse together. They grow together. So that happens. I need my wrist one because it's dripping all over my foot. The sacralization happens during embryological development, which is that first 9 months that you're in the uterus. So you're born with it, basically. It's not something that happens as a result of an injury, and you don't need to treat it, by the way. It doesn't do anything. Huh? We're almost done here. I want you to notice there's not really any bleeding. There's two reasons for that. The laser coagulates tissues like capillaries and small vessels, but also the disc itself doesn't have a blood supply except for the outer part where we are right now. And there's definitely a blood supply out here. It's called the outer half of the annulus. So if you take the annulus, you divide it in half. The outer half has a blood supply. The inner half does not. But people wonder, why does it take so long to heal from surgery on your disc? The answer is there's no blood supply. You need a good blood supply to heal anything, whether it's your skin, your muscles, whatever it is, any tissue in your body. You need a blood supply to heal that tissue. So there's really two types of tissue that don't have a blood supply. Two main tissues, I should say. And one of them is the disc, the inner part of the disc, the nucleus. And the other one is the lens in the eye. Doesn't have a blood supply. My God, this is all scar tissue from chronic inflammation. Incredible. Huh? Just incredible. A little bit of bleeding from some of the veins inside the fat around the nerve. Why is there fat around the nerve? Energy, that's correct. Energy. So it's normal to see fat around a nerve. As a matter of fact, if you look at an MRI, you'll see that the nerve leaves the spine in the neural foramen, and there's a lot of fat there. Okay? That's because that nerve needs energy, and it uses fatty energy. Okay? Can nerves use fatty energy? Yes. Can the brain use fatty energy? I see someone shaking their head. Jordan, awesome. No, it cannot. The brain is the only tissue in the body that cannot use fatty acid energy or fats. So if somebody tells you, you know, you want to lose weight, use your brain more, they're not talking about actually thinking harder, because the brain doesn't burn fat. It burns glucose and only glucose. That's the only energy source. However, nerves themselves can burn fats and glucose. So we frequently see fat. Oh, man, what a herniation. This is the monster of herniations. Looks like the Niagara Falls here of scar tissue. So the nerves themselves can use fat. That's why you frequently find fat cells in the foramen around the dorsal root ganglion. The dorsal root ganglion is a cluster of neuronal cell bodies, and that's really what uses the energy, is the cell bodies. Nuclei, which are clusters of neuron cell bodies, not axons, they use tremendous amounts of energy, the soma, or body of the nerve, and that's what the dorsal root ganglion is, and it's a sensory nerve. It's a cluster of sensory nerves, and sensory nerves are very busy nerves. They're constantly giving your brain feedback about feelings in your legs, your arms. So they need lots of energy to do their job, just like my staff need energy. This is why I bought them mole today, chicken mole.
We have a couple more questions.
Sure, we'll take those questions.
We have another viewer from Facebook who's wondering, can the heat generated in the tissues by the nerve fiber damage the nerves or spinal cord?
All right, so can the heat generated in the tissues? That's the question. From Facebook, YouTube,
Facebook.
from Facebook viewer, says, can the heat generated by the laser in the tissues cause damage to the nerve or spinal cord? The answer is yes, it can if it's not done properly. But what we do here at Deuk Spine is the proper way, and there cannot be heat damage to the nerve or spinal cord, as long as you adhere to my technique that I use every single surgery, the same way. Okay? And that has to do with the laser settings, and it has to do with the temperature of the irrigation being cold. All right, we're just about done. This is one of the longer discs. How much energy have we delivered, by the way? Probably in the 40s. 40.38? So 40, like I said. So we've delivered 40 joules of energy, and that's a lot. Those are some of the, normally we do somewhere in the 20, 30 joules. We had 64 once. Yeah. And by the way, I can ramp this up. We're delivering 30 watts. I could ramp this up to 90 or even 100, but I'm not, by the way, because it's not safe for the patient or the staff. So this is perfect. I've been using this setting for 16 years that I've been doing this, and it works beautifully, but I use different settings in different parts of the body. So thoracic and cervical use a different setting. Lumbar uses a different setting. But yes, the setting is very important on a laser, but also the irrigation and the time that I deliver energy to the tissue. So the work, man, this is like at least 10-year-old injury. Some of this disc injury is over 10 years old. I can tell. Yes.
We have another question.
Sure.
So a viewer from Facebook is wondering, does the fact that the laser is straight inhibit you from getting to certain areas where herniation may occur?
Does the fact that the laser is straight keep you from getting into certain areas where the herniation may occur? It's a good question. The answer is no, it doesn't, and yes, it does. So, okay, I don't know. That sounds like a surgeon to me. I'm happy to answer the question. I have been doing this for 16 years with basically 100% relief of pain from the discs and leg pain. So 100% relief of back and leg pain. I always say 98, but the reality is virtually every person is 100%. I've not even seen anybody less. So the reality is that the straight laser works. So there's an old saying, if it ain't broke, don't fix it, right? You could make the argument to use a side-firing laser because it would make it easier to get to some of these things. But since I've had 0 complications in 1,300 cases with a straight laser, and I have basically 100% cure rate of disc pain, why would I change it and put on a side-firing laser? So you may say, well, then you can get some of those tricky herniations that are off to the side there, and you're correct. But then again, how is that going to benefit the patient? You see, for too long have we done medicine to benefit the doctor and our egos. We need to focus on what's best for the patient. And what's best for the patient is to get rid of their symptoms and not have a complication. And that's exactly what this surgery with the straight firing laser has done for the last 16 years. So if those are my goals, eliminate symptom and avoid complication, which is what every surgeon should be doing, by the way, then why would I change what I do? I've been asked that before, not about this. I have been asked about the side firing laser, but I've also been asked by companies that want me to use their endoscopic equipment and say, oh, ours is better, ours is better. Really? Shouldn't I be the judge of that? So my patients ultimately are the judge of whether it's better or not. Okay, we're done. Laser off. And quite frankly, I don't feel compelled to change my technique and what I do because something else is available that's different but unproven to be better. In other words, if you're getting the very best results possible, humanly possible, why change? Light off, scope off? I don't want to change. And that's my answer. Sure, I could get a side-firing laser. Sure, I could use it. And, you know, maybe I have good results, maybe I don't. But I'm not willing to take that chance. Not unless I need to. And so far, out of 1,300 endoscopic surgeries in 16 years, I have not found a reason to change what I do. But it's a good question, it's a fair question. Next.
Yep, we have another question. Another viewer from Facebook is wondering, can pinched nerves cause pain related to shingles?
Can pinched nerves cause pain related to shingles? So let's break that question down because it's not a simple answer. I'm going to first show you, I take this little roll, I put it here, and I'm putting pressure not on the incision, but on the muscle. And the reason for that is sometimes we'll get a little capillary bleeding and it'll travel up through the hole. And I don't want that. I don't want that bleeding in the muscle because if you get any blood in the muscle, you're going to get, that blood's going to break down over the next month or two. And as it breaks down and the body reabsorbs it, it's totally harmless, but it will cause irritation of the muscle. And the irritation will manifest as muscular pain and spasms. And so I've had one patient many years ago. He was a performer on Disney Cruise Lines, and he had the laser surgery done. And at the time, I wasn't aware that the blood pressure, you know, because as a neurosurgeon, we don't manage blood pressure typically. We let the anesthesiologist do it, and they usually do a fine job. They want to keep the patient perfused, so they keep the blood pressure up. They don't want the heart having a heart attack or the kidneys failing So they keep the blood pressure up. That's their preference. But having a higher blood pressure means your patient's going to bleed during surgery. So the bleeding, of course, happens in the muscle in this type of surgery or around the spine. And we don't want either of those things because intramuscular hematoma or a blood clot is going to cause muscle spasms and muscle tenderness after the surgery. And everybody has a little bit of tenderness from the surgery, but if I can eliminate that blood in their muscle, then I can avoid them having some discomfort afterwards. So I'm just trying to make their recovery as comfortable as possible. And it is possible, as long as you keep the blood pressure, down around 110, 100 to 110, 115, and you put pressure on the muscle afterwards so that it doesn't form a hematoma. I can feel a hematoma in the muscle. There's no hematoma. If you go to the store and you take an inch or 2 inch thick piece of steak and you just push on it with your fingertips, if it's fresh, you can feel it give, and that's what it should feel like. If you have a hematoma, it gets hard. And so I don't feel any hematoma, but I want to keep it that way too. So if you put a little bit of pressure for about 3 minutes, sometimes 4 minutes, then you can avoid getting an intramuscular hematoma, which is not anything serious, but you can avoid the patient from having discomfort after surgery. Now, some intramuscular hematomas are serious, okay, but not with an endoscopic incision and approach. With 6 millimeter skin incision and a very narrow channel through the muscle, you're not tearing the muscle or cutting the muscle, you're just spreading the fibers. So really you're looking at possibly getting some capillary bleeding if you're unlucky, maybe a small vein, but it's easy to control it by putting 10 millimeters of mercury pressure on the muscle, and that keeps the blood inside the vascular system and does not let it extravasate into the muscle. So you won't get that irritation of the muscle afterwards. What other questions do you have?
That was all of our questions currently.
Did I get the answer on that last one?
Yes, you did.
Are you also typing in some answers?
Yes, I'm typing in all of your answers.
All right, we've done the biggest disc herniation at L5-S1 down here, and now we're going to do the L4-5. So same approach. It's going to be the guide wire down through the needle, then we're going to get rid of the needle. Now notice we've lost maybe a drop of blood the whole surgery. So this basically, Deuk Laser Disc Repair surgery that we do at Deuk Spine is bloodless surgery. You don't lose blood. I probably lose more blood than the patient does. Brushing my teeth, that is. But that's only when I brush my teeth. I got a couple of chuckles. All right. What do you need a favor for? Jordan, you're off. You see the pedicles are not lined up. Try to wag it back. Probably on my side south. The IV pull needs to be closer.
Yes, because it's created too much tension.
All right, Jordan, are you done? That's better. That's probably fine. All right. So at this point, we're going to do the next disc, L4-5 shot. I want to make sure the guide wire stays in position as I remove the needle. Let's see. By the way, for those of you who don't know, Deuk Spine Institute has an app on the iPhone and the Android. You're welcome to download our app for free. There's no charge. And use it to learn more about spine conditions. We've been working on the app, and we've got a new version coming that's going to have even more information, and it's going to be even better organized. And so it's going to be a wonderful way to go in and learn about herniated disc, bulging disc, and the treatments that are available, the diagnostic tests that are used to diagnose the conditions. And yeah, we're working on improving things all the time. Also, we have a Roku channel that's coming, the Deuk Spine Institute Roku channel, where you'll be able to 24 hours a day watch streaming surgeries, interviews, testimonials. We're developing a series of animations as well of the spine to help people understand exactly the differences between different types of treatments and understand the pathophysiology of spine disease a little bit better. Remember, 90% of spine problems are what are called degenerative, which is what we treat here. I would say trauma is also an important cause, but I include trauma in the degenerative because the truth is that all degenerative conditions of the spine affecting the joints, the discs and the joints, they all have their origins or arise from traumatic injuries, okay? All of them. So I could feel the tear. Now this one doesn't have a big tear, and the tear is mostly going to be healed, but that's why we're not going to need to do very much. I don't expect to. Of course, saying that, now I've jinxed myself somehow, which shot, but we want to make absolutely sure we're addressing everything abnormal. Yep. While we're here. That was his request. Shot? Yeah. All right, so we're not going to need to do very much, like I said. This should be a quick one. Now, compared to the other disc we just did, the other disc at L5-S1 was really scarred, had a lot of calcification, and thank you. And honestly, that was like really bad. That clearly had been damaged multiple times and had partially healed each time. And he kept injuring it. And by the way, once you damage your disc and you get an injury like that, like a tear with a small herniation or bulge, it's so easy to damage it again with just minor trauma, like bending, lifting, twisting. So you get these flare-ups of back pain. Or if it's in your neck pain, or if it's in your thoracic pain. And so that last disc we did had been damaged many times, you could tell, over the years. All right, laser?
We have a couple more questions.
Sure, I'll take the questions. Save a question or two for when I come out of the surgery, which will be in about 5 minutes.
Okay.
And I'll answer them directly.
The earlier viewer from Facebook wanted to clarify their question about shingles. They were wondering.
Oh, I apologize. I did not finish it.
Yeah, they were wondering if shingles causes inflammation on the nerves that can be made worse by a herniation.
I really couldn't hear the question, Sean. I mean, your voice is just a little bit too low. I remember it said something to do with shingles and a compressed nerve, but I don't know. I don't know exactly what they're trying to find out.
Well, they're trying to find out if shingles can cause nerve compression or make it worse when you have a herniation.
All right, I apologize. I got sidetracked there. Shingles, for those of you who don't know what it is a viral. It's a post-viral problem that affects nerves. Okay, so if you've ever had chicken pox, you know what herpes virus is, and it's called varicella zoster virus, VZV, and it basically gets into the nerves themselves and lives in there, okay, after the chicken pox is gone. So if you had chicken pox as a kid, which we all do, it's a viral infection. It causes vesicles in the skin. You get these blisters on your skin. They're about the size of a quarter or dime, and they're very painful, and the kids cry, and thank God it happens at a time when you don't remember. All right, but the reality is that those virus particles never go away. So the virus lives inside what's called the dorsal root ganglion, which is, remember I showed you the fat earlier, and I told you the dorsal root ganglion lives in the foramen, that hole where the nerve comes out. That's where the dorsal root ganglion is. So this virus lives within the nerve bodies, the cell bodies of nerves in the neuroforamen that are the dorsal root ganglion nerves. These are sensory nerves. So they control feeling, like down in your body, like in your thoracic, in your flanks or your back, or even down your arms or legs. So at some point in life, you can have a reactivation where the virus starts to go into production again. Somehow it gets triggered. And the trigger for that, we believe, is stress, okay? Stress. And some people are more susceptible than others. It could be genetics. It could be the different types of viruses, like variations of the virus. Some are more virulent, which are more aggressive. Others are less. Point is, you get a reactivation of the virus as an adult. It travels down the nerve fibers to your skin, and it creates blisters. That's what viruses do by killing your cells, your skin cells, all right? So they blister up. And the blisters themselves are not so painful, but the fact that the virus has distorted the function of the sensory nerves and causes even the lightest touch to be so painful with a burning type of pain. So shingles is the adult disease where you get a reactivation of the virus in the nerves, traveling down the nerve fibers to the skin, causing blisters, and it's so painful, and it's a burning sensation on the skin. That has nothing to do at all with pinched nerves. Nothing whatsoever. Pinched nerves are a completely different problem. They are completely unrelated to the virus. However, think about it. Remember, what activates the shingles is stress. So if you have back pain and a pinched nerve, it could cause enough stress that it would cause a, wow, that's so cool. Look at that pink stuff right there. That's a blood vessel and some granulation tissue. That's the tear, by the way. If you look at the discogram, you don't really see it, but it's there. It's just that it healed pretty well, but I still think it was painful. There's granulation tissue right there, that pink stuff that I just zapped. Just hit rewind and you'll see it. But this is all part of the tear at L4-5. So this disc needed to be treated, and I'm glad we did. And we couldn't really verify that it was painful because the patient didn't want to do that discogram, the evocative discogram. He just wanted a chromodiscogram. The difference between a chromodiscogram and evocative discogram is the evocative discogram is with the patient awake. You're evoking a response or trying to evoke a response, whereas a chromodiscogram is with the patient asleep, okay, where you're not evoking a pain response. So getting back to the shingles and the pain and the compressed nerves, there's no relationship in my mind directly between pinched nerves and shingles. However, if you're suffering with chronic back or neck pain, that causes tremendous stress. If you've taken steroids for it, like those Medrol dose packs, those 7-day pill packs, those could reactivate shingles. Steroids are known to reactivate shingles. I don't know if that helps. Either way, we treat both conditions. The shingles pain is called post-herpetic neuralgia. We treat that at Deuk Spine. There are advanced treatments we provide, such as sympathetic ganglionectomy, where Dr. Patel will go in with a needle and zap away the sympathetic ganglion and treat it. But we do those treatments here. There's also creams and stuff we could use if you don't want to do that. And we can do blocks, sympathetic block. So we do treat post-herpetic neuralgia at Deuk Spine Institute. Deuk Spine Institute is a comprehensive center where we treat virtually every spine condition, every pain condition that there is, okay? And if we can't treat it, we'll tell you, we'll send you out somewhere else. But somewhere we trust. You have any more questions? You have one or two more? Sean?
We do have another one. Let me see here.
Just one?
We have two more right now.
All right. You want to save them? Because I'm just about done here.
Okay, we'll
I
answer them
need
in the
2
post-op.
minutes and I'll be done. Okay, doctor? So I'm going to head over to the conference room and I'll do a face-to-face with you all. We're just about done here. By the way, the blue staining there is the chromo part of the discogram. It's the chromo means a dye, a vibrant dye, a light sensitive dye. And that's blue. Of course, blue is not normally found in someone's disc. That's something that we added so that I could find the what's called the degenerating nucleus pulposus. Very important. Normally, nucleus pulposus does not degenerate, okay? You could be 90 years old and have non-degenerated nucleus material in your disc, and that's expected. But once you damage the disc with an annular tear and you create inflammation within the annulus that seeps down onto the nucleus and gets the nucleus involved in the inflammation, which is very common, by the way. Almost everybody has at least one degenerated disc. That degenerative process is a process that is overseen, activated, manifested through inflammation. And so the dye binds basically to nuclear material that is degenerated, that has been under the influence of inflammation. Oh, look at that little herniation there. It's very smooth. It's been acted on by inflammation. So, like I said, this disc is different. It has a very different appearance than the last one. This disc is more normal. And this patient is how old? 60? 65. So this patient has still normal discs in his back that are totally normal, but this is not one of them. And the one we did first is not one of them. So these are the two abnormal ones. But the other ones, if I put the blue dye in them, there would be no staining because there is no degenerated nuclear material. All right, I'm coming now. Oh, this is it, the end of it right here. And I'll be heading up to answer your questions. So go ahead and type up questions. Once again, Deuk Spine Institute has the app, the Deuk Spine Institute app. It's free. You can download it, learn a lot about back and neck conditions that cause pain and the contemporary treatments for it, including state-of-the-art laser surgery like you're watching now. Also, you can join our Facebook group. It's free. It's called Spine Surgery Support Group. We do moderate it and check it every day. So if you have questions, you can post your questions. And we have really a wonderful community in the Facebook support group. We don't have any trolls. Trolls are evil people that for some reason feel that they should be keeping valuable curative information from people. We believe in a free flow of information that's truthful. And we promote that through our app, through our website, through our video, surgery videos like the one you're watching now, and our Facebook support group. All right, 30 seconds, we're going to be done. And I'll head over and answer the last couple of questions. Done. Scope off. Tell Dr. Patel we need him. Perfect. All right. So, those of you watching, tube is coming out. Take. I am putting pressure on the muscle just to keep it from having any bleeding. And then I'm going to leave and head over to the conference room in just a minute. Luis will put the Band-Aid on. Yes, sir. But you saw it's a tiny little incision. I've got a Raytech off the field coming through. All right, type your questions up and I'll answer them for you, folks. But you've just watched the Deuk Laser Disc Repair, the most advanced surgery in the world, the safest surgery in the world, and the most effective surgery in the world available today for treating herniated disc or bulging discs that are causing pain. If you're not sure where your pain's coming from, or you know somebody who has back pain or neck pain, do them a favor. Send them the Deuk Spine Institute's website. We do a free MRI review, which we look at the MRI, and then we also do an interview of the patient through Skype, where I can confirm the source of their pain by doing a physical exam. Thanks. And yeah, be happy to help out. We do that for free, by the way. We don't charge for MRI reviews. That's why they're free. And we don't charge for the Skype reviews either. I'm going to call our EBL 1 mil. Hello everyone, I'm Dr. Ara Deuk-Majan, CEO and founder of Deuk Spine Institute, the home of the Deuk Laser Disc Repair. The only surgery in the world that has been peer-reviewed and published effective for curing back pain, neck pain, thoracic pain, and radicular symptoms. We just completed another surgery live. This patient has come to us from out of our area. We do a lot of medical tourism. People want to know, can I travel there and get the surgery done? 100% you can, no problem. We have patients that come from all over the world. We even had a patient ask, can I pay in Bitcoin? And the answer is yes. Dogecoin, I don't know yet. No, I'm kidding. If I say yes, we accept Dogecoin, will the price of Dogecoin go up? What do you think? I'm getting some blank looks here, but I think some of you know what I'm talking about. That said, the surgery was successful. We did not do a discogram with the patient awake this time. We did a discogram with the patient asleep. That was the patient's request. I normally don't do that, but I'm willing to do it on occasion, on a case-by-case basis. That said, this patient should be out of the operating room in about 10 minutes once they wake up. They're getting their Band-Aid put on right now, and then they're going to go to recovery where they'll spend probably about an hour, and then they'll be ready for discharge. I know we still have some questions. We had some really good questions during the surgery, and I was very impressed with the questions you're all asking. Once again, this is a live stream surgery, and it is May 13th, 2021. I'm Dr. Ara Deuk-Majan, the head surgeon here at Deuk Spine Institute. So, Sean, what questions do we have?
So our first question comes from a viewer on Facebook who's wondering, what are the chances of a herniation leaking out again as it does quite often with mechanical microdiscectomy?
So we have an amazing question. Thank you. And you said it was Facebook? One of our Facebook viewers. So the question was, Dr. Deuk, you do this amazing surgery, and of course I'm adding that adjective, and you go in there, and basically, for those of you who don't know what I did, this is a model of the spine. Those are two bones, vertebrae, and between them is a cushion called the disc. You can see how big it is. That's my finger right there. So you can see the disc is pretty good size. And by the way, the discs in the lower back are bigger. The discs in the neck are much smaller. And that's because the discs in the lower back have to bear more weight. As a matter of fact, the discs in the lower back are bigger because they carry the weight of the entire body from the belly button up, okay? It goes through that disc, about 85% of the weight. Now, the other joint that there is this thing called the facet joint. You see that? How does that look, Sean? Right there? See that joint right there, folks? Right here, the facet joint. So you got two joints with every two bones. You got two joints. You got the facet joint in the back, and you got the disc up front. That's this big guy right here. Now, what traditional spine surgeons do, called the microdiscectomy or laminectomy, they're going to come on the spine from the middle. This is the middle of the spine. So they're going to make an incision in the back of the spine about that long, and then they're going to peel the muscles, and maybe the toothpick isn't the right tool, but they're going to peel the muscles off of the spine, literally peel them off, shave them off, pull them off to the side, anchor them around the facet, and then they've got this bone right here, okay? And I'm going to look to the side so I can see what I'm telling you. I'll use this side because that's where the herniation is. They're going to remove all of this bone and joint right here, and the ligament between, right in here, to get down to the herniation right there. The red thing is the herniation, okay? So that's a traditional approach, microdiscectomy. That's what you want to avoid because it weakens the spine. What we do here at Deuk Spine with the Deuk Laser Disc Repair is I come from the side instead of through the back. I touch this joint here, and I go just lateral to it, and I pop into the herniation, just under the nerve root. And I apologize, I'm going to have to hold the nerve root up a little because it's sliding down. So this is the view I have. I come through here, and basically I enter right into the disc, right through the herniation. And I can push the herniation back into the disc as I do that. I use the laser, I clean up the herniation and the tear, and then there's a little gap there where it was. You can all see that at the end of the surgery. So the question is, what's the chance that the jelly will leak out through that gap before it heals? So that gap that's created at the end of the surgery is going to heal, for sure. And it's going to heal with the same material that your body produces to make the outside of the disc in the first place. Okay? So let's look at the disc. You've got the jelly in the center. That's the red stuff. And it's normally white color, obviously, in the human body. It's just red because we want to be able to see it with this little disc. And then you got this thick stuff out here that's kind of a yellowish color. All right? That's called the annulus fibrosus. And the annulus fibrosus has the same characteristics of, if you eat a piece of steak, that really tough, chewy rind around it that you don't normally eat, at least I don't, that really strong rind is made of collagen, and that wraps around the jelly, which is in the center. So when you have an annular tear and a bulging disc or herniated disc, you're actually rip through that collagen, the rind, and it lets the jelly push out. Now, here's the problem. I go in there and I laser all this up so that it'll heal properly, because it's not healing properly. That's why people get pain. It's trying to heal. You have inflammation going on, but it can't heal because the jelly is wedged in there. So I cleaned all that out and I've got a gap now, okay? So there's a hole in the annulus. It looks like this. Over the next year, what happens is the disc starts to slowly heal, okay? It comes back together and then it heals really strong. The healing really strong is the end of healing. End of healing takes about 9 months to a year to end of heal. All right? At that point, the disc is basically back to normal, very close, as close to normal as you can get it. So what happens if another injury occurs before that annulus seals off and closes the hole? That's possible. But the disc material is not it's not like, we call it a jelly, but it's not runny like strawberry jelly or grape jelly. It's not just going to ooze out of the hole. It doesn't do that. It's very clumpy. It's more like, almost like a jelly crab meat, if you could think about it that way. It's more congealed, it stays together, and the only way it's going to go out through that hole is if you bend forward and pick something heavy up, or if you're twisting and carrying things or lifting something heavy. That carrying and twisting and bending puts pressure on the disc. The bones literally get squeezed down by the muscles and the load that you're carrying, and push pressure on the disc. The bones come together and squeeze, and that pushes the jelly, that can push the jelly out through the hole. So for everybody that has this surgery, they get a back brace made out of plastic and Velcro that they can take off to shower, and they get restrictions on bending and lifting. And those restrictions are gradually better and better over the ensuing months after surgery. So what's the chance that somebody has this surgery and it's done perfect and then they re-herniate? The chance is 1%. About 1% of my patients that I do the perfect surgery on will re-herniate. And so I can't control that. That's something that we try to reduce the likelihood by doing restrictions and back brace. But ultimately, some people, they're feeling so good after the surgery that they go out and they do something they're not supposed to do, in my opinion. And on the rare occasion, they'll get a reherniation without even doing anything, okay? So I would put the chance of getting a recurrent disc herniation at the same area where I did the surgery at about 1%. That's what our number is. Did I answer the question? And by the way, it's much higher with a microdiscectomy. Microdiscectomy, you're looking at probably around, a recurrent herniation rate at a microdiscectomy, you're looking at probably around 50%. But those that become symptomatic and need medical attention and surgery, you're probably looking at around 10% to 20%. Depends on the surgeon doing the surgery.
Our next question comes from Facebook as well. He was wondering, Dr. Deuk, I have 2 bulging discs in my lower back and a fractured tailbone. What should I do now?
So we have a viewer who says they've got 2 bulging discs. So those are disc herniations. They're called contained disc herniations. They can be very painful. And then they have a broken tailbone, which I don't know what that means. I don't know if they're talking about the coccyx. So if we look at a tailbone here, okay, it's a big bone. You can have a crack through the actual tailbone itself, or you can have the little piece at the bottom could be broken. So I'm not sure what they mean by broken tailbone, but if it's a crack through the sacrum, then we could do something called a sacroplasty, where we put a little needle in there and fill that cracked area with cement to reinforce it. That's minimally invasive, can be very effective. On the other hand, if they're talking about the little bone that hangs off the bottom, called the coccyx, sometimes that can be damaged by like falling on your butt, and that will become, displaced, or it could strain the ligament. We do a shot in the ligament to reduce the pain and just let it heal. As far as the herniated disc go, the bulging disc, I would do the laser surgery if they're causing symptoms for you. That's the best surgery for you. There's no metal, there's no fusion, there's no hospitalization. We do all this outpatient, and we've had very, very good success without any complications. It's the way to go. Just so those people who don't know me very well, I've been doing neurosurgery 26 years. I've been trained to do every single kind of spine surgery available out there in the world. So anything that any surgeon has ever talked about, whether it's correction of deformity, instrumentation, decompression, realignment, kyphoplasty, spinal cord stimulator, whatever it is, interspinous device, I've done it. I know how to do it. I can do it probably with my eyes closed. That's how easy it is to do these surgeries. But the reason we do the Deuk Laser Disc Repair is it is the safest, most effective surgery in the world by far for a herniated disc or bulging disc in the neck, thoracic, or lower back. That's the one I recommend. If I had a painful disc, that's what I want for myself, and that's what I would want to have done.
Our next question comes from a viewer on Facebook who's got a slightly more neurosurgical question. They're wondering, Dr. Deuk, is there such a thing as neuroplasticity?
Is there such a thing as neuroplasticity? Yes, neuroplasticity 100% exists. What are they talking about? So, great question. We all start out life as basically a one cell organism, okay, in utero. And through the next 9 months, after the sperm and the egg get together, and the sperm injects its DNA into the egg, and you start to develop, hopefully in a uterus and not in a test tube, but the future you never know these days, or a petri dish. You grow and develop in the uterus, okay? And think about that for a moment. You start out as one cell, and you divide and divide and divide and divide, and each of those cells divide. And something happens as the cells divide. At first, the cells all look the same. They look the same structurally, physiologically, they're very similar. But then this very complex process occurs as development occurs in the uterus and in the embryo. You have these interactions that go on between cells that are near each other and away from each other, using signals, chemical signals, biological signals. And what those biological signals do is they cause cells that start out very much looking like each other, acting like each other, to what's called differentiate, where they change morphologically, they change their structure, they change their appearance. Kind of like if you're looking at a house, you have areas where there are glass, where there are bricks, where there is stone. And so these cells all start out the same, but then they differentiate and they look different and they function different. Some of the cells become muscles, some of them become skin, some become bone, some become cartilage, some become neurons, okay? And so the neuron cells are the ones that are going to form the brain, nuclei of the brain, and the nuclei on the spinal cord, and hence the neurons, the axons, the nerves of the human body, the electrical system, the computer system. So what is plasticity? Plasticity is the ability of groups of neurons to assume functions that they normally, did not have. And the reason for that typically is that the neurons that were created to do those functions died out. Essentially, they died. Either through trauma or a vascular process like a stroke, where typically in the first 10 years of life, okay, let's say a child has a bad stroke and they lose the right side of their brain. Well, the neurons from the left side of the brain and some of the right side that are surviving can actually take on the functions that were ascribed or embodied by the nerves, the neurons that died. So basically, it's kind of like if our director of nursing were to quit her job and move somewhere, then the nurses that are here that are not director of nursing, some of them would take on the management job, some would take on recording or documentation jobs. So they would expand their abilities and their function to accommodate the missing roles. Sorry. I hope that makes sense. So we see plasticity every day in work. We see it in life. When an individual is supposed to be doing something and then they leave, and then the people that are left sort of take on those jobs and responsibilities a little bit each. That's plasticity. So neuronal plasticity happens. We know it happens. We know it happens for sure. Quite obviously in young kids who are under the age of 10, 12, their brains are plastic and they can have an injury to an area of neurons and then the other ones will take over the functions. And now we also think it might happen to a degree at a lesser extent in adults as well, because stem cells that are called pluripotent or totipotent, meaning they have all potential or major potential to do many different things, they can actually get activated and differentiate to become neurons and assume neuronal responsibilities. Hence, that's another example of plasticity. Good question.
Our next question comes from another viewer on Facebook who's wondering if I have lumbar facet arthrosis and disc narrowing vacuum changes at 4-5-5-1, is that something that can be treated with laser surgery?
Yeah, so one of our viewers says, hey, I got pretty advanced degenerative changes on my MRI, X-ray, CAT scan that show vacuum disc phenomena and, bone on bone and collapsed disc, very advanced degenerative changes. Can the laser still work? 100% yes. The laser will work for that. We've done it many, many, many times. The laser can work anywhere from a bulging disc, which is like a minor change to the disc structure, all the way through to completely collapsed discs that are causing pain. The laser will work for those, honestly. Yeah. And even if you have spondylolisthesis, where the bones are slipping, up to a grade 2, the laser will work for that as well in about 95% of the time. Only when you have a spondylolisthesis and there's a congenitally narrow canal where the bones are slipping and then the nerves are getting crushed between bone in the back and bone in the front, then the laser won't work for that. But I can tell that by looking at the MRI. I can tell whether or not the laser will work. So 90% of grade 1, grade 2 spondylolisthesis, even scoliosis, kyphosis, the laser works to take pain away. It doesn't correct the deformity, but it takes the pain away.
Another question is an interesting one. A viewer is wondering, does the discogram dye or the laser cause any side effects long-term, like cancer?
Does the discogram dye or the laser cause any long-term side effects like cancer? Absolutely not. Laser and the dye do not cause cancer. Great question.
Right. And last question is, can you elaborate a bit more on cervical stenosis and how it differs from lumbar stenosis?
Sure. So the question is asking me to talk a little bit more about stenosis in the cervical spine and lumbar spine, and are they different? So stenosis essentially means narrowing. And when you look at the spine, and I'm going to use this model to illustrate this, okay? I want you to look at it. I'm going to rotate it around for a minute just so we can all get a better idea of what's going on. The spine is made up of these bones called vertebrae, okay? And this is one vertebrae. Let's see if I can help you see that better. Just to make more sense, I'm going to use a different model. It's definitely warm in here. Okay, so check this out. I'll show you what I'm doing here. So this is part of the spine, right? So let's look at the big spine. You can see there's two vertebrae and the disc between them. So we'll just look at this for a moment, all right? And then now let's just take a look at one bone. So this is called a vertebrae, and it is the building block of the spine. And you've got these from your tailbone running all the way up to the skull. Now, of course, as they go higher up, they get smaller, and they change a little bit because in the thoracic area you have ribs, so this part changes a little bit. And in the cervical spine, you actually have blood vessels going through, so there's a hole here to let the vertebral artery go up. But these are things I wouldn't focus on. The main thing to focus on is that this is the unit, okay? Now, when you put two of them together, you don't, to have movement, you have to have movement between one bone and the next bone, okay? But if they're just, bones are just moving with respect to each other and they're touching each other, they're gonna rub on each other and they're gonna cause massive bone spurs and they're gonna degenerate, and the spine is basically gonna become totally diseased by the time you're like 10 years old. You won't be able to walk, all right? So God put cushions between the bones we call them joints, but the big cushion is a disc, and in the back there's cartilage between these bones that allow movement, okay? You see that? Movement. And there's cartilage back there. But the disc is the big cushion in the front. This is where most spine problems happen. That's what we treat. Spinal stenosis occurs. Now I'm going to take the spinal cord and nerves out for just a minute so you all understand what's going on. Okay? So I'm taking out the nerves and the spinal cord. Now I'm just going to look at the spine itself. So the spine itself has these building blocks called vertebrae. And if you look here, you can actually see there's we call it the canal, and it's a canal, all right? And this canal runs literally from the bottom of the skull all the way down to your tailbone. You see the canal right there? That's called the central spinal canal. So what runs in there is the spinal cord or nerves. They run in that canal right there. You all see that? Right? Now, every segment or every gap between the two bones, nerves come out through these holes right here on the side of the spine. So there's the front, there's the back, there's the canal, and now these are called the neuroforamen. Neuroforamen, okay? Neuroforamen. That's this hole right here. I'll show you this side as well. Neuroforamen, that's where the nerve comes out. And it's the nerves that go down your arms or legs. And they control your muscles. They go to your skin and you can feel things like hot, cold, pinching, pain, whatever. If you step on a nail or a rock, it hurts. That's because the nerves take that signal up to your brain. Now this is a normal neuroforamen, okay? Right there. That's a normal neuroforamen. This is an abnormal neuroforamen because there's a herniated disc back there, jelly pushing out through a tear, and it's narrowing the hole where the nerve comes out. So it's called stenosis. Stenosis. Stenosis means narrowing. So this is an example of foraminal stenosis. And then if you have narrowing here, like if there's a big herniation, you see that? If I push a herniation there, and now you have central stenosis. You all see that? Now if there's a spinal cord in there like there is in the neck, then that herniation will push on your spinal cord. So there's really 3 types of herniation, really 4, but the 4th one is so rare I don't want to talk about it. So there's 4 types of stenosis. There's central stenosis, which is narrowing of this central canal. There's lateral recess stenosis, which is narrowing off to the side right before the nerve exits. Then there's foraminal stenosis, which is narrowing of this area where the nerve comes out. And the foramen is defined as the space between the pedicle, above and below. Okay? And then there's extraforaminal stenosis, which is narrowing out here. And that's the rare one we're not going to worry about. So, what kind of stenoses are important? They're all important, but the most important one by far is lateral recess stenosis and foraminal stenosis. That's where nerves get pinched the most. So when people have pinched nerves, it's always lateral recess or foraminal stenosis. And that's what the Deuk Laser Disc Repair surgery treats the very best, is that stenosis. Oh, let me put the nerves back. Do we have any other questions?
That was our last question.
All right, I hope you enjoyed the surgery, and we'll be back for another one soon. The next patient travels from Canada for Deuk Laser Disc Repair. This last patient traveled from South Florida. And so we have a lot of traveling patients who come here because you can't find this surgery where you live. So you plan on coming to Orlando and spending a few days with Mickey Mouse and Donald Duck and Pluto, whoever your favorite Disney character is, and visiting Duke's spine and getting your back or neck fixed.